Good evening, everyone. I'm here to talk about rabies, and these are my objectives for this report. We all know that rabies is a fatal disease, and it affects about 150 countries and costs about 8.6 billion per year. It usually occurs in rural areas of around Asia and Africa, and it's very important in our practice because it affects 40% of children under 15 years old. The main source is still dogs, and 50% of them are our pets. In the Philippines, most cases are found in Region 3, namely Bulacan, Tarlac, and Cebu province. In CAR, it is about 1%. Males usually are predominantly the victims compared to the females. As such, the WHO had programs wherein they have to reduce deaths from dog-mediated rabies by 2030, and in the Philippines, wishes to eliminate rabies by the end of the year and declare Philippines as rabies-free by 2022. As such, they enacted numerous policies and management strategies in order to combat rabies. And the primary intention was rabies prevention. Dog vaccination is one of the primary strategies wherein it prevents the spread of the virus from the animal to the humans, and human vaccination, which may be subdivided into pre-exposure prophylaxis and post-exposure prophylaxis. With regards to post-exposure prophylaxis, there are three main parts, namely local wound care followed by vaccination, either by active vaccination or passive vaccination. So what are we going to do if you get bitten by a dog? First of all, local wound care is very important. Immediate and vigorous washing or flushing with soap and water for 10 minutes is necessary. If no soap is available, thorough wash with running water for at least 10 minutes. You can apply antiseptic and or give antibiotics if there is frank infection or need prophylaxis, as the case may be. For large wounds, suturing should be avoided. But if it needs to be coaptated, you can use sterile adhesive strips or can do secondary wound closure. If unavoidable, you should give your immunoglobulin infiltrated around the bite area and may be sutured after only 2 hours after administration of your immunoglobulin. Sutures should not be closed or given ointments or creams because it may promote bacterial growth and may occlude wound drainage. And of course, for every wound, you should give your tetanus prophylaxis accordingly. Now we go to the review of categories of bite. For category 1, which is described as feeding or touching an animal, licking of an intact skin, exposure to patients with signs and symptoms of rabies, such as sharing your eating or drinking utensils, and casual contact to symptomatic rabies patient. What you do is proper wound care with soap and water, and no vaccine or immunoglobulin is necessary. For category 2, bites, which is described as nibbling of uncovered skin with or without bruising or hematoma, minor or superficial scratches, abrasions without bleeding, or induced bleeding, which is very common in rural areas, you could give your vaccine immediately after doing your local wound care. Immunoglobulin is necessary. Take note that all category 2 bites on the head and neck are considered as category 3. For category 3 bites, there is contamination of your mucous membrane with saliva from licks or licks on broken skin, or exposure to rabies patients through bites, contamination of the mucous membrane, open skin lesions with body fluids, mouth-to-mouth resuscitation, unprotected handling of infected carcasses or ingestion of raw meat, or direct contacts with bats, and all category 2 bites on head and neck as was described earlier. You should immediately do local wound care and start your vaccine and immunoglobulin immediately. Of course, we do not forget the biting animal. We should observe the animal for at least 2 weeks, providing, and if the animal is sick or dies, you should consult the veterinary or send the animal for study of negri bodies accordingly to specified laboratories around the country. So there are 2 types of immunization that can be given. First is the immunoglobulin, which provides immediate protection but is only short-lived. And for the vaccine or the rabies vaccine is an active immunization and provides long-term protection with antibodies appearing after 1 week to 10 days after vaccination. There are two types of vaccine that can be seen. One is the purified virus cell rabies vaccine and the purified chick cell embryo cell vaccine, which are produced by the Sanofi and GSK companies, both of which are WHO pre-qualified vaccine. However, there are non-WHO pre-qualified vaccine produced by the following companies, which are written in green. These are used in cases that there is shortage of the pre-qualified vaccine and should satisfy these requirements. They are recommended during shortage of WHO pre-qualified vaccine. They are approved and registered by the FDA, proven safe and efficacious for post-exposure prophylaxis. Potency is noted at 0.5 international units per ID dose or intradermal dose, and the product insert contains approved intradermal dose. So how do you give your post-exposure regimen intramuscularly? You can have your 5-dose regimen at 1 dose each given at day 0, day 3, day 7, day 14, and day 28. You can also give a shorter dose of 4-dose regimen at day 0, day 3, day 7, and day 21. Or a much shorter dose for day 0, 2 doses, day 7, 1 dose, and day 21, 1 dose. These are both given for pre-qualified and non-WHO pre-qualified vaccine. For the intradermal dose, you could give it via the Thai Red Cross regimen at day 0, day 3, day 7, and day 28 with 2 doses each given on each day of the prophylaxis. And the Institut Pasteur de Cambodge for pre-qualified vaccine at a shorter dose can be given at day 0, day 3, and day 7 with 2 doses for each day of the post-exposure prophylaxis. Take note that the giving of intradermal vaccine should be given by a trained professional and that a 3 millimeter wheel should be attained upon given. If it is done improperly, you should repeat the dose accordingly. It is important also to note that to store the vaccine at 2 to 8 degrees Celsius and should be used within 8 hours if opened. In intradermal dosing and intramuscular dosing, you could give it into the anterolateral thigh of infants and the deltoid area for adults. It should not be given in the buttock area because absorption and antibody production is not very good as such. So for the immunoglobulin or the passive vaccine, there are 2 types. Your human rabies immunoglobulin, which is preferred in cases of hypersensitivity to equine sera, multiple severe exposures, symptomatic HIV patients at a dose of 20 international units per kilogram per dose. For the equine rabies immunoglobulin, previously, skin testing is required, but now it is not required before administration since skin testing is not a very good indicator of adverse reaction, and it's not a requirement for giving the immunoglobulin if necessary. Furthermore, immunoglobulin are given in a clinical setting wherein the physician should be aware and prepared to manage as anaphylaxis. The equine rabies immunoglobulin is given at a dose of 40 international units per kilogram per dose. So the guidelines for immunization for passive vaccines is that the rabies immunoglobulin should be given at a single dose for all category 3 exposure or in combination with anti-rabies vaccine. The immunoglobulin should be infiltrated around and into the wound as much as anatomically feasible if the lesion has begun to heal. You should avoid multiple needle injections for passive immunization, and if it is given in the toe or fingers, need to be infiltrated so that care must be given and not to impair circulation in those areas. Immunoglobulin should also not exceed the calculated dose, as it may reduce the efficacy of the vaccine. And if the calculated dose of the immunoglobulin is insufficient to the infiltrated bite area, you could dilute it with sterile saline for 2 to 3 folds for thorough infiltration of the bite area. Even if there is an infection, you could also still give your immunoglobulin in the bite area. In instances where immunoglobulin is unavailable, you should give your immunoglobulin within 7 days from the first dose of the vaccine. if not given together with your immunoglobulin, the vaccine should be given before the immunoglobulin, and that the immunoglobulin is only given once during the course of your post-exposure prophylaxis. Special conditions like pregnancy, elderly, newborn, immunocompromised, and sick individuals can be given the post-exposure prophylaxis even with these specified conditions. If we have a individual with previously immunized with rabies or had their pre-exposure prophylaxis, we have first to determine if they have complete vaccination of their rabies vaccine. Namely, either they were given the day 0 and day 2-dose regimen of day 0, 7, or day 0 or in day 3 regimen of pre-exposure prophylaxis. Hence, immunoglobulin is not necessary for these cases. It is important to note that to determine if the bite is either high or low risk. If it is a high risk bite, the criteria are as follows. Biting animal cannot be observed, or dies, or is sick. The site of bite is in highly enervated body parts. There are multiple deep bites, or the patient comes in areas where services for medical attention is lacking or are at a disadvantage. As such, you should give your booster dose either 0.1 ml ID at 4 sites on day 0 or 0.1 ml ID or IM at the site on site day 0 and day 3. For low risk bites, this criteria should be followed. The last dose of the vaccine was in the previous 3 months. The biting animal is healthy, owned, or can be observed within 2 weeks. And any of the following: the biting animal is the same animal that have bitten the individual, the biting animal is previously immunized, or the bite is on the extremities. You could observe the animal for 14 days. If the animal remains healthy, you could withhold the booster dose accordingly. For immunocompromised patient, you could, even with complete pre-exposure, post-exposure prophylaxis, and is immunocompromised, such as inactive HIV or been bitten by a bat, you should give your immunoglobulin as necessary and give the full course of your post-exposure prophylaxis. And for individuals who has not completed their post-exposure or pre-exposure prophylaxis, you give your immunoglobulin as indicated and the full course of your post-exposure prophylaxis. Other guidelines that should be remembered is that the initiation of your post-exposure prophylaxis shall not be delayed for any reason regardless of the interval between exposure and consultation. For immunocompromised individuals, they can be given either IM or ID regimen and immunoglobulin for category 2 and category 3 exposures. Patients with hematologic conditions wherein IM dosing is contraindicated, you could give the vaccine via the ID route. If there is a delay in consult, treat as if the exposure occurred recently, and if the biting animal has remained healthy and alive for at least 2 weeks, no treatment is necessary. For babies born with rabid mothers, vaccine and immunoglobulin should be started immediately as possible. Interchangeability of rabies vaccine brand is not recommended, but if warranted, it should not be restarted, but to continue according to the program. As much as possible, the initial regimen or route should be completed. However, if unavoidable, there is no need to restart, and the schedule of the new regimen should be adopted accordingly. Should a vaccine dose be delayed for any reason, the post-exposure regimen should be resumed, not restarted. With regards to biting animals, all bites should be given tetanus prophylaxis, but bites from rodents, rabbits, and guinea pigs should not be given any post-exposure prophylaxis. For other domestic animals and such as cattle, pigs, and horses, you should give your post-exposure prophylaxis. For vaccinated animals, such as your pets, post-exposure prophylaxis is not recommended for Category 1 exposures, and post-exposure prophylaxis can be delayed for Category 2 bites, provided that the following are satisfied. The dog or the animal is healthy and available for observation for 2 weeks, has been given rabies vaccine for the past 2 years, must be at least 1.5 years old, and has an updated vaccination certificate, and the last vaccine must be within the past 12 months. However, if the animal becomes sick or dies, post-exposure prophylaxis should be started immediately. Even though vaccinated dogs have leeway in giving your post-exposure prophylaxis, the following post-exposure prophylaxis should be started immediately in the following conditions. Category 3 exposure. The dog or cat is proven to be rabid with no laboratory examination for rabies and not available before or during the consult. The dog or cat is involved in at least 3 biting incidents within the past 24 hours, and the dog manifests behavioral changes suggestive of rabies during and after the biting incident. For pre-exposure prophylaxis, the following are the benefits. There is no need for immunoglobulin once bitten by a dog. Pre-exposure vaccine regimen is reduced from 5 to 2 doses. There is protection against rabies, and the cost is significantly reduced. The target for pre-exposure prophylaxis are namely personnel in the rabies diagnostic or research facilities, veterinarians and veterinary students, animal handlers, and healthcare workers directly involved in the care of rabies patients, or field workers involved in rabies control. And also in areas wherein there is a high incidence of rabies, it can be given for children aged 5 to 14 years old, as stated by local guidelines. So how do you give your pre-exposure prophylaxis in an immunocompetent individual? Previously, it can be given IM or ID with 1 dose each at day 0, day 7, day 28, or day 21. For the new regimen, for pre-qualified vaccines, can be given 2-day regimen, IM at day 0 and day 7, and ID with the same days, day 0 and day 7, with 2 doses each. For immunocompromised patients, you could give your dose 3-day regimen, IM only, at day 1, day 0, day 7, and day 21 or 28. For the new regimen, for WHO pre-qualified vaccine, can be given either IM or ID at day 0, day 7, day 21, or day 28, with ID dosing at 2 doses per site. Pre-exposure prophylaxis can also be given via the deltoid muscle or anterolateral thigh for infants, and there is no need to restart the series if doses are not given on the exact schedule. Individuals taking chloroquine prophylaxis may use IM or ID regimen provided that the vaccine is given first before taking in the chloroquine regimen. It is not indicated during pregnancy, and booster doses can be given for individuals with continuous or frequent risk involving rabies. Booster doses are given 1 year after completed pre-exposure prophylaxis, and serologic testing may be done every 6 months to 2 years. If the booster is necessary, if antibody is less than 0.5 international units per ml. Routine booster doses are not generally indicated for the general population, and the regimen booster is given at 1 dose 1 year after the pre-exposure prophylaxis. If in the event that there is an exposure or an animal bite, it is only indicated for patients who have completed their pre-exposure prophylaxis. You should assess the exposure whether it is high or low risk, as was discussed earlier, and if needed be, you should give your booster regimen according to the regimen that was discussed earlier. For those who are given only 1 dose of the pre-exposure prophylaxis, they should be treated and given the full course of your post-exposure prophylaxis. For the booster doses of routine booster given, or those who are at high risk of rabies exposure, they may opt to use the vaccine brand or regimen other than the one used for the primary immunization. For example, you have started using the PVRV, and you could do your booster with PCEC or vice versa. Also, if there is repeated exposure or bites, you should always assess the nature of the bite, if it is high risk or low risk, and the vaccination of the biting animal. And that concludes my lecture. Stay safe and thank you.